Hi everyone, and welcome to the Geriatric Healthcare Lecture Series. This is, I think, Lecture 7 in the spring terms, no, Lecture 8, and we have 2 more in this series. My name is Barbara Cochran, and as usual, I am representing the Northwest Geriatric Education Center for this lecture series. I also direct the DeTournier Center for Healthy Aging here in the School of Nursing, and have really appreciated all of your participation in this series this academic term. I wanted to mention again that you can contact your site coordinators to get signed up to receive contact hours for attending these lectures, and to remind you, if you haven't attended one of the lectures before, to please fill out one of the profile forms, which you can also get from your site coordinators. We use that information just as a way to report participation to our funding agency, and fingers crossed we'll continue to get funding and be able to offer this series in years to come. Today I'm very happy to introduce to you Dr. Joseph Merrill, who's going to talk with us about alcohol in older adults. Dr. Merrill is a UW Associate Professor of Medicine. He's also a certified expert in addiction medicine, and he has clinical and research expertise in primary care, addiction medicine, pain medicine, and HIV medicine. As a member of the UW School of Medicine College's faculty, he's active in medical student education. He teaches students, residents, and practicing physicians in a wide variety of settings, and has been active in integrating addiction medicine into primary medical care settings. So we're really pleased to have you here, and I'll let you tell them about the chatting. How's that?
Great. Thank you. Happy to be here, talk about alcohol in older adults. I'll divide this talk into 3 sections and give you a little heads up when I'm about to end each section so you can do some questions. I learned a bunch about alcohol in older adults in preparing this talk. I found out that really a lot of it's similar to alcohol in other people, and so a lot of the information is pretty general for your understanding of how to deal with alcohol in primary care settings. Rich Sates, Jared Klein, and Jocelyn James helped with some of these slides in various talks. So I'm going to talk today about the presentation of alcohol issues in older adults, the screening, assessment, and diagnosis of alcohol issues and unhealthy alcohol use. I'll talk about brief interventions for unhealthy alcohol use, and then a section on pharmacotherapy for alcohol, really an area where we need to focus our attention on delivering more care. And then the last section's really on motivational enhancement and sort of how to deal with behavioral issues in the primary care setting. So alcohol, as you know, affects many organ systems, pretty much all of them, and you can see a number of issues on this slide: dementia, depression, I see stroke, cirrhosis, of course, osteoporosis, a lot of things that overlap with medical problems in older adults. And so alcohol tends to be kind of a comorbidity with a lot of issues and presents very differently in older adults because of that. So if you look at epidemiology of alcohol in older adults, you do notice that people drink less as they age. However, we certainly have in the baby boomer generation a different cohort, and higher rates of substance use are known. So as the baby boomers age, we're going to be seeing more substance use, alcohol use, and the consequences of that in our geriatric populations. The main thing to remember with alcohol in older folks is that there are big differences in how alcohol is metabolized. The liver slows down, the metabolism of alcohol slows down, and so that for every drink that someone has, their blood alcohol concentration and their amount of impairment goes up. So this lowering of tolerance is a really important thing to keep in mind. It's also can be more difficult to identify problems related to alcohol in that social issues, which is often how we figure out whether people have alcohol problems, might be more difficult to see or understand when folks are retired. Risk factors for alcohol problems in older adults include being male, being white, having other medical problems, having chronic pain, and then also taking a lot of other medications. So you can see there would be other issues going on if you're seeing these patients, and it's easy to miss alcohol problems. The way alcohol problems may present, depression, irritability, poor coping, or sleep problems are quite common in older adults. And actually, if you look at some of the epidemiology, actually being richer is associated with more drinking, and then life events such as bereavement or unexpected retirement or isolation often lead to increased drinking. And then prior substance use disorder is a risk factor in older adults, but you have to keep in mind that 1/3 of all alcohol use disorders develop later in life. So it's not just folks who've had problems before who have problems as older adults. And it's very easy for these to go unrecognized. So this is the pyramid of alcohol use, and this is for everyone. A lot of people abstain. A lot of people have what we call low risk use. That's the bottom of the triangle. And then the top part of the triangle with the orange outline is unhealthy alcohol use. And so that's this segment here. And then within that, there's two main areas: risky use or problem drinking on the bottom, and then alcohol use disorders, or the diagnosis that goes in DSM, is just this top part of the triangle. So when we're looking in primary care or in a geriatric population, what we want to identify is not just folks who have a disorder. Alcohol dependence or abuse is what we used to call it. Now we call it alcohol use disorder. But we also want to find these other folks who are in the unhealthy alcohol use category. And so that's the issue in primary care, is finding that bigger triangle. So the reason we want to find this out is that many complications of alcohol use are more common in folks who don't have a diagnosis of an alcohol problem. So in this case, injury and alcohol, you can see that out of the 10% population attributable fraction that is related to alcohol, more than half of it, or 6.6%, are among people who don't have a diagnosis of alcohol use disorder. Even though it's more common in folks who have alcohol use disorder, that's a much smaller population. So what's a risky amount of alcohol? This is for the National Institute on Alcoholism and Alcohol Abuse has criteria for what constitutes safe drinking and risky drinking. For men, greater than 14 drinks a week or greater than 4 per occasion is risky drinking. For women and for older adults, that number is half that, so 7 drinks per week or 7 per occasion. And you can see here, this is just examples: 12 ounces of beer, 5 ounces of wine, a shot of spirits counts as 1 drink. So that doesn't mean that everybody who drinks this much has problems with alcohol, but it puts them at higher risk, and therefore is it's good to intervene on. As far as drug use, I'm not really going to talk about that today. It's really difficult to find any amount that's not risky when you're talking about drug use. So low-risk alcohol use, we hear in the paper that moderate alcohol use is associated with health benefits. We have to understand that in the context of the studies where we've seen that there is an association with low amounts of alcohol use, and people actually have better health than people who abstain from alcohol. But you have to understand these are observational studies, and there's never been a randomized trial comparing low amounts of alcohol to no alcohol, and these trials are biased in ways that may affect the outcome. So the trials often don't characterize drinking very well over time, and you have to realize that low consumption of alcohol is associated with a lot of markers of really good health. So people who people who exercise, people who eat more healthy, people who aren't overweight, tend to consume low amounts of alcohol, and that biases the results of some of those studies. It's also true that people who drink a lot may quit because of complications related to alcohol, and those are called sick quitters and may bias the data as well. So we don't have, so we don't have any evidence of benefit of alcohol, even at low levels, to recommend alcohol to prevent anything. So if you're going to screen for alcohol, we actually have gotten this one down to one single item screening. And that, after you ask, do you sometimes drink beer, wine, or other alcoholic beverages, just ask one simple screening question. How many times in the past year have you had, I'm going to say, 4 or more drinks in a day? That would be for women or for those over 65. For men, it's 5 drinks in a day. And this, it's a screening test, so it's not perfect. But if they say anything but 0, there's a pretty good sensitivity and specificity, not for having alcohol diagnosis, but for unhealthy alcohol use. And if you do get more than 8 times in the last year, that's actually a pretty good surrogate for having alcohol use disorder or dependence. So here's what you get when you ask about how much people drink. There's 72% of folks in the U.S. Never exceed those daily or weekly limits, and almost none of them have an alcohol use disorder. Folks who just exceed the daily limit, that's the 4 drinks a day or more for women or those over 65, most of those people, 8 out of 10, only do that less than once a week. And the number of folks in that category who have an alcohol use disorder is 1 in 5. And then people who exceed both limits, almost half of those people do have a disorder. So we've often been taught, well, what about the CAGE questions? Those are probably the questions that most people have learned for alcohol screening, and we've replaced it with this single item screener. The CAGE is, have you ever had to cut back, or have you ever been annoyed by people who are worried about your drinking, or have you ever been felt guilty about your drinking, or ever needed an eye opener in the morning, or feel like you need to calm your nerves with a drink in the morning? Those are questions that are very good for identifying people who have ever had an alcohol use disorder, but they're not quite as good at uncovering unhealthy alcohol use. You can see that it's not a very sensitive test for unhealthy alcohol use. It is a pretty sensitive test for folks who have an alcohol use disorder. So that's why we don't use CAGE anymore, because it's really more about finding people with a diagnosis, and we're interested in finding unhealthy alcohol use. So another way to go would be to ask people, do you drink? If they say yes, you can do the CAGE, so you have a sense, do they maybe have had a problem that's a diagnosis? But then if whatever the response, you kind of want to understand among current drinkers how much they drink. So you can ask, how many days a week do you drink on a typical day? How much do you drink? And then what's the maximum number of drinks on any occasion during this last month? And that kind of gives you a combination of ways of finding out unhealthy alcohol use. So a lot of people will follow up a positive screening test with more specific information, like what I just talked about with the consumption questions. The AUDIT-C is really well validated, and really are those questions about consumption. And this is kind of sort of a part of a how bad is it kind of assessment, not just is there something I need to assess. And you can see that you have to score it, and it's a little bit more complicated than just a single item. So screening in older adults compared to the rest of the population, actually they're less likely to be screened if you look, and that may be due to stigma. It may be that folks in primary care have so many other issues to address they don't get to the alcohol screening. And a lot of alcohol symptoms do overlap with medical issues. So, and it may also be true that older adults just don't recognize that they have problems with alcohol. There are some screening tests that have been developed specifically for older adults. I don't generally recommend them in a primary care setting, but if you were in a clinic where you just treat older adults, you could consider using these. And how they're different, I've given this example of the comorbidity alcohol risk evaluation tool, more for just to understand what's different about screening in older adults. So this tool would assess quantity and frequency, just like we talked about, and it would also assess the presence of comorbid diseases, high-risk behavior like are you drinking and driving, and then medications that may interact with alcohol. So it ends up being a little broader and more specifically focused on older adults. There's a couple of other tests. The Michigan Alcohol Screening Test for geriatrics is another test that you can use, and the ASSIST is actually a World Health Organization screening for alcohol and a bunch of other substances. So what do you do if you do get a positive screening test? Well, the key issue here is to assess for an alcohol use disorder. And you can use the CAGE to help you figure that out, but I generally recommend people have a conversation. Tell me about your drinking and see what people say. Have you ever had problems related to your alcohol use? And I think just asking these pretty direct questions can really get a conversation going. And then, have you ever had any treatment for an alcohol problem? That kind of gives you a sense, well, at one point they did have a diagnosis, and then you can assess current drinking and problems related to that. There are new criteria, we'll go over them, from DSM-5. They generally come out when you just have a conversation. You don't necessarily have to do a checklist, but you can do a checklist if you want. But I don't generally recommend that. Usually you can figure it out with a conversation. And really the goal here is to differentiate patients who have risky use or unhealthy alcohol use but don't have a diagnosis with folks who do have a diagnosis. And we need to do that because the treatment is different. So alcohol use disorder, this is the DSM-5, and I've listed the criteria. There are some differences between DSM-5 and DSM-4. So now we call it alcohol use disorder. We don't call it alcohol abuse or dependence anymore. And there's a severity range now assigned to DSM-5. Basically, it's the same criteria as alcohol abuse and dependence in DSM-4 with a couple of exceptions. One is that the craving or urge to use is a new criteria, and one at the bottom, the recurrent legal problems, is no longer a diagnostic criteria. For tolerance and withdrawal, DSM-5, this is more related to substance use rather than alcohol, but if you're getting a prescription for a medication and you just have tolerance or withdrawal from that, it doesn't count as part of an alcohol or substance use disorder. And then you count up the symptoms and you can figure out if they have a mild disorder, a moderate disorder, or a severe disorder. The moderate to severe disorder really corresponds to alcohol dependence in DSM-4. You can also think about alcohol use disorder with the key principles. Do they have negative consequences? Do they have craving, tolerance, and withdrawal, and kind of fit most of the criteria into one of those. I'm just going to go through DSM-5 in older adults because there are some differences to consider when you're thinking about these criteria. For instance, substances taken in larger amounts or longer period than intended. It may be in older adults, they may have some cognitive impairment and they may not be great at self-monitoring. So must have to consider that. The persistent desire to cut down is really the same in older adults. A great deal of time spent using or recovering from. It may be that the older adult has more consequences for small amounts of drinking. So could be harder to tease that out. Craving is if somebody's been drinking for many years and really doesn't ever stop or has an entrenched habit, it could be difficult to tease out. And then the resulting in failure to fulfill obligations at work or school or at home, that may be different for older adults in that they may not have the same role obligations, and that may be harder to tease out. The same for using in spite of social or interpersonal problems caused by the substance. People may not realize, or it may not be as obvious. And then other criteria, social, occupational, recreational activities given up. Well, older adults may be giving up some activities for other reasons as well, so harder, again, to detect problems. Use in physically hazardous situations. It may not, they may only need small amounts of alcohol to be hazardous. So again, that lower tolerance is an issue. And then people, again, may not realize these problems are caused by substances. Tolerance, we've talked about, it doesn't go in younger adults. One of the diagnostic criteria is that you get more tolerant and you need more to get the same effect, but with aging, it's the reverse. And then withdrawal could be more subtle in older adults. So there are some of these criteria that are endorsed less frequently by older adults, and they're the ones with the asterisk. They're here. And there are some that are the best criteria in older adults, and those are persistent desire to cut down use in spite of social or interpersonal problems, and the withdrawal. So that's just a review of DSM-5. There are other ways to go about this assessment. This is a website you can refer patients to for a self-assessment, and it's actually quite good. Rethinking Drinking, you could refer patients. If you don't have time or patients are not sure they want to talk about it with you, you can give them this resource. And then, of course, there's a million signs or symptoms that might be related to alcohol, so really the screening approach is what you recommend. All of these things can be affected by alcohol or caused by alcohol. So I'm going to move on to talk about brief interventions for unhealthy alcohol use. This is in the primary care setting, and brief interventions are what you do when you have a patient with unhealthy alcohol use who does not have alcohol use disorder. So, and those are the patients these have been tested on. There's a really strong evidence base in support of brief interventions. It reduces the proportion of people with problem drinking by about a quarter, reduces consumption, and these effects do seem to last for a long time. They're short, they're 5 to 10 minutes, they're empathetic, and they're repeated. The repeated part is actually important. The elements of brief intervention would include three main things. One is clear feedback. You're drinking more than is safe for your health, and that could be because they're drinking over the amount that is recommended, or it could be that they're drinking within that amount, but they have a medical condition that means that they shouldn't drink at all, hepatitis C, or they have a cardiomyopathy, or something that alcohol directly impacts. And then clear recommendations: you should either quit, depending on the situation, or no more than one drink per day. And then, are you willing to cut back? And if the patient says, no, I'm not willing to change anything, then it's good to just talk about, well, what's good about alcohol, what's bad about alcohol, kind of get people talking about what the better things are and what the not so good things are about alcohol, and then just make your recommendation and follow up with them. If they do say they want to cut back, then you want to go into making a plan and following up. And I'll talk a little bit more about the sort of style of interviewing for this later in the talk. So brief intervention has a lot of studies, like I mentioned. This is interesting in that the brief and very brief ones, which are up in the top corner, up this upper left-hand one, these are some studies, and the ones that are negative are the ones in red, and the ones that are positive in the sort of brown. You can see there's not as many positive studies in this section as the ones who've had brief, multi-contact kinds of interventions. So these are the ones that have the best evidence base, and you can see an example here on the left. It would be like giving a health booklet, having a 10 or 15 minute physician discussion, a couple of them, and then a nurse follow-up call. That's what a brief intervention trial looks like, and that's where the best evidence is with these multi-contact things. So this is the last slide of this section. If people have questions, they can start getting them ready. The key concepts with the brief intervention literature are that these are trials that were all done with patients who were identified by screening. So the single item screener followed by a little more assessment. The best evidence for brief intervention is folks who don't have an alcohol use disorder, and we've talked about what that means. They do have unhealthy alcohol use, and they've been recruited in a primary care kind of setting. And the evidence of efficacy for outcomes beyond the sort of consumption is limited. There is some evidence for reduction in medical costs, but there's not that much evidence for our efforts at linking people from primary care to specialty care. And if you do this kind of screening and brief intervention in the emergency department or in a hospital setting, it's not as clear that that's effective. Older adults do seem to respond as well or better to brief interventions compared to younger adults. So definitely this is something that applies to the geriatric population. So I'm going to take a little break. Let's see, we have about 5 minutes. So if there are questions, I'm happy to take them on this sort of screening, brief intervention section. Yeah.
So the term, you don't use the terms alcoholic and alcoholism. Do you hear you use that at all? So alcoholism is now, AUD is what would be used. And I guess why each time the DMS changes, things, that terminology changes. What's the rationale for changing the term?
Great. So should I repeat? Yeah. So the question is about terminology. It's not alcoholism. It's no longer alcoholism, alcohol abuse or dependence. Why did DSM change this this nomenclature? And the main reason is that the alcohol abuse and dependence was really the dependence part was confusing, really, because physical dependence, like having tolerance and withdrawal, that's what physical dependence is, got confused with addiction. Like, what's an addiction? It's not just tolerance and withdrawal. It includes these other consequences of use. So the idea of substance dependence, really, it was felt to be confusing. So that's why they ditched it. It's now addictive disorders is the chapter heading, and then alcohol use disorder or substance use disorder or whatever other drug use disorder. They're all the same nomenclature. And some of it has to do with stigma. We don't use alcoholism just because a lot of people, I'm not an alcoholic. And that may be true, that stigma and the patient's perception is very different. We kind of want to make it a little bit more medicalized so people can understand it. That's the same thing with unhealthy alcohol use. We're not saying that anybody's an alcoholic or even necessarily has a use disorder, but they can still have use that will impede their medical problems or make trouble medically or in terms of their health.
So Talkeetna is asking, at what age do we see the BAC increase with age? Yeah,
I'm not sure that I can tell you the answer to that from my knowledge of the data, but my understanding is that it's just a gradual process of aging, and when people get to 60 or 65, that's when it's looking like people's tolerance starts to go down. But it's a gradual process. Obviously depends on other medical problems would be interacting with that as well.
I don't have any other questions right now.
So we can go on to the next section. And really here I'm going to be talking about, this was the brief intervention was really talking about what to do with unhealthy use without an alcohol use disorder. And the next part is really managing folks who do have moderate to severe alcohol use disorder. A few points to keep in mind. If you try and get people with alcohol use disorder and you try and get them into detox, that may be the first step in their treatment, but it really isn't treatment. It's just getting them through a medically dangerous situation. And then brief intervention, we really talked about it's most effective in these unhealthy alcohol use people who don't have a disorder, but people use brief interventions to try and help folks with a moderate or severe alcohol use disorder get to other forms of treatment. And then treatment can be counseling. There's a lot of different kinds of counseling that are used for folks with alcohol use disorder. And there's pharmacotherapy, which is really what I'm going to focus on now because pharmacotherapy is not well delivered in the specialty treatment setting. And it's something that primary care docs can do, and it can really improve outcomes. And then there's self-help, mutual help, AA kind of thing, where we can encourage patients to go. And there's even a form of treatment called 12-step facilitation, where the counselor is really trying to get people to look at using AA and how to use it most effectively. So there's a whole range of treatment. the first thing you have to figure out when somebody has a moderate to severe alcohol use disorder is about their alcohol withdrawal. So there are, and really it's not that hard to figure out. If people have had bad withdrawal before or been hospitalized, they're likely going to need it again, and you know it's a high-risk detox. If people are in the outpatient setting and have gone more than 36 hours without many symptoms, they're not going to likely get into trouble. If they've never had other risk factors like been hospitalized for alcohol withdrawal before, and they have somebody who can watch them at home, that's an outpatient setting. And in that setting, it's really okay to treat with anticonvulsants for alcohol withdrawal. You don't need to use benzodiazepines in that setting, even though you do need to use them in the inpatient setting or when alcohol withdrawal is more severe. You got to consider having people in the hospital if they've had seizures in the past, if they're using other drugs along with the alcohol, if they have bad anxiety, have been through a lot of detoxes, or their BAL is high. And then inpatient, definitely when people are older and have concurrent illnesses, have had problems with withdrawal in the past, or DTs, delirium tremens, ever in the past. Those are all people who need to be in the hospital if they're coming off. And then after people get out of a detox, there's a lot of different kinds of ways to figure out how to help them with maintaining that and preventing relapse. And here's so the main thing that a primary care doc can do is really anticipating those situations which are triggers to alcohol use, and just doing problem solving with patients to try and help them deal with those, trying to emphasize their success in the past and using that relapse as a learning experience, sort of coping with the triggers with cravings, and help them develop a plan if they do slip or have a relapse. And then treatment can involve, like we said, the 12-step groups, counseling, pharmacotherapy, dealing with other kinds of mental health problems that are comorbid with the alcohol. And that's kind of the overview of treatment. And then in older adults, there's not as much evidence as there is for younger adults, but it does appear that for older adults, treatment is at least as effective as or maybe even more effective than in younger adults. The problem really is that older folks don't tend to utilize treatment. There's a lot of stigma around treatment. A lot of older adults have problems with isolation, trouble with payment, or transportation. These are barriers that have been cited in older populations seeking treatment. There are some programs that are tailored to older adults, and they have actually better evidence than the traditional treatments, but they're kind of hard to find. So if there are programs that have older adult treatment, that's worth looking for. And then traditional addiction treatment definitely has some limitations related to older adults. The group setting can be difficult. Again, that stigma, or not feeling like they're in the same situation as younger folks who are dealing with alcohol use disorder. And some treatment programs are pretty confrontational about their approach to treatment. That doesn't seem to work well in older adults. So the best data in older adults, the brief interventions seem to work. There's some models called supportive therapy and cognitive behavioral therapy, which has been applied to many kinds of addiction treatments. And then medication, these seem to be have the best data in older adults. If you're thinking about pharmacotherapy for alcohol, and I really encourage you to, that's part of why I'm here, everybody who has a moderate to severe alcohol use disorder, who's currently drinking or experiencing a lot of craving and are really at risk to return to drinking, all those people are candidates for pharmacotherapy. And what you have to consider when you're thinking about pharmacotherapy is, the specific medications, and we'll go through that, and the contraindications. You do want to think about what kind of support you can supply or the patient can access. There have been studies showing that doing primary care, just medication management, kind of like what we do with antidepressant or anti-anxiety medications in primary care, may be as effective as actually specialized treatment that's more manual based or professionally delivered. So I think that, and then you have to figure out who's going to prescribe and how are you going to monitor the patient. Often just keeping up with visits and tracking those patients can be a challenge. And some patients who have liver problems related to the alcohol, you might want to monitor those as well. So in the addiction world, it's often called medication-assisted treatment. And that means, whether it's for alcohol or other drugs, that you're doing treatment, it's a psychosocial intervention primarily, and you kind of add the medication on. And that's what medication-assisted treatment means. But you wonder about whether it's really more like counseling-assisted pharmacotherapy. Maybe the medication is the part to focus on and how we're going to deliver that, and then you add some counseling. And there's a lot of evidence that it's probably more like the latter. You don't need to do a ton of counseling if you're doing a medication, and it's just as effective as doing a lot of counseling with the medication. So there's a bunch of ways that you can learn about this. This is a publication that's available at the NIAAA website, Helping Patients Who Drink Too Much. A lot of what I'm talking about comes out of this, and it's got information about treating alcohol dependence with all the medications and the interactions and the contraindications. The FDA-approved medications for alcohol use disorder include disulfiram, which is antabuse, Acamprosate, which is called Campral, the brand name, and then naltrexone. And that has two formulations, Revia, which is an oral formulation, and Vivitrol, which is an intramuscular formulation. There are also a number of non-FDA approved medications, especially the top one, topiramate, has a kind of level of evidence that would allow FDA approval, although it's now generic and they're not going for that. But it has a lot of evidence. And then these other medications have a variable amount of positive evidence for the use of alcohol in alcohol use disorders. So, for instance, on ondansetron, it's not useful for everyone, but folks who have early onset alcohol use disorder seem to respond to it. Gabapentin, it's been used alone, and with naltrexone, it is effective for withdrawal. And so it may be actually attractive because many primary care docs know about how to use it and know the side effects. And baclofen, maybe, maybe not. And there's a number of other medications that have been tried. So just going through the neurochemical circuits that are involved in alcohol dependence and craving, these have really been specified pretty well. And the issue is that there are a bunch of them. So there's pathways related to opioid pathways. There's pathways related to glutamate. And so there are multiple. There's multiple targets for medications that may help with alcohol dependence. So going through the medications, you'll see they interact with different neuro pathways and to affect alcohol use. So most of the trials that have dealt with pharmacotherapy for alcohol have started with folks who've gone through detox and are abstinent, also all people with moderate to severe alcohol use disorder. Disulfiram and Acamprosate are best started after detox. You have to start disulfiram after a detox for sure, otherwise they'll get sick. And naltrexone actually is one that has been experimented with in folks who haven't quit drinking yet, and that may be a big advantage of that medication. The goals in pharmacotherapy is either abstinence or potentially reduction in heavy drinking. And we went over what the heavy drinking is in terms of greater than 5 drinks a day for men, or greater than 4 or more for women, and 5 or more for men. And it's interesting because if you look at the measure of alcohol use that's most closely associated with negative consequences, including medical problems, it's actually the number of heavy drinking days with this definition of a heavy drinking day. So if you can reduce the number of heavy drinking days, you may actually reduce consequences of alcohol use a lot without requiring abstinence. The duration of treatment for pharmacotherapy is usually a couple months to 6 months, and most people recommend at least 6 months of treatment, generally longer, 6 months to a year before stopping the medication. So the first medication we're going to go over is naltrexone, and it is a mu opioid receptor antagonist, so it blocks mu opioid receptors. And the mu opioid receptor is associated with reward and craving, so blocking that can be good. The dosing of it is either 50 milligrams a day for the oral formulation or this once a month 380 milligram IM injection. It is safe in active drinkers, and it does seem to have its most effect in moderating how much people drink. So again, those heavy drinking days seem to go down. It is contraindicated if patients are taking opioids because it will block them. There's some caution if they have really bad acute hepatitis, like greater than 5 times the upper limit of normal, and folks in liver failure, you can't really use naltrexone. It reduces heavy drinking by almost 20% compared to placebo. It does have some side effects. Nausea is the most common one. Usually you can get through it it gets better over time, and you can lower the dose from 50 to 25 milligrams to get people started if they're having problems tolerating it. And then the intramuscular formulation is pretty expensive, and you can get injection site reactions to that. And then, so the efficacy of naltrexone, there's a bunch of studies. Bottom right-hand corner there, you can see relapse to heavy drinking is lower in the folks who get naltrexone. So this is an example of naltrexone. This is the intramuscular version, and you just focus on the bars to the over here. So these are people before they come in. This is the heavy drinking days per month, median of 20. You can see where they started entering treatment and getting a placebo. You can see that the heavy drinking days goes down quite a lot. This is just with the placebo. And then there's a dose response, so lower and lower amounts. But you can see a big effect of just getting a medication coming into treatment. I'm not going to focus on this part. There weren't very many women in the study, and there was a question of whether there was a dose response. But the main point here is that just getting a medication and some medication management can be really helpful for folks. Acamprosate's the next medication. Alcohol releases glutamate and NMDA, and that is associated with withdrawal and reward. The Acamprosate blocks the release of glutamate and NMDA in these pathways. It's not completely clear how it works, but it does block pathways known to be associated with alcohol problems. The dosing is the big problem with the Acamprosate. It's a 3 times a day medication, funny dosing, 666 milligrams per 3 times a day. You do have to worry about the kidneys here. If the GFR is less than 50, you have to lower the dose. And it does, it seems to have its effect more in promoting abstinence rather than reducing the amount that people drink. Again, it's not a huge effect, but the 86% of placebo, there's not that much effect on heavy drinking. And then there are different results in Europe and the US. We're not exactly sure why. It may be that the US populations that have been studied were less severe and had shorter duration of abstinence when they started the medication. We're not 100% sure. It is safe in liver disease. It's not metabolized or excreted through the liver. You do have to dose adjust in renal failure. And the side effects include diarrhea and nervousness and fatigue. Again, these improve after you've been on it. It's really quite easy to tolerate this medicine as well. This is the sort of summary of efficacy of Acamprosate. If you look on right here, you see abstinence at 1 year. There's a statistically significant difference in this meta-analysis. So disulfiram is the last one I'm going to talk about. Ethanol is metabolized to acetaldehyde and then to acetate, and disulfiram blocks the second step there so that there's a buildup of acetaldehyde, which is toxic, causes headaches and nausea and flushing. So if you're on antabuse then or disulfiram and drink, then you get sick, and that's how it works. Typical dose is 500 milligrams a day for the first couple weeks, and then you can lower it after people are on it to 250 daily. And it potentially cause problems with drink, in other words, make people sick up to 14 days after they use it, although for many people it's not really that long before they can drink. It is contraindicated in recent alcohol use because it'll make you sick, and if you have bad coronary disease, it's probably not a good idea, because if people drink and get an anti-abuse reaction, they could have a heart attack. And then psychosis and cognitive impairment are other concerns. Folks who have bad liver disease and recent drinkers obviously at risk. And then there was a meta-analysis of trials. Disulfiram was approved by the FDA decades ago, and there was a trial that did not find efficacy compared to placebo. So it may not be FDA approvable today, although it is still available. It doesn't have much in the way of side effects, maybe a little bit of fatigue. But if you look at the meta-analysis and look further into that, there's a difference between disulfiram when it's just given to the patient versus given to the patient and somebody else who is going to monitor their use. So monitored disulfiram, there have been a number of studies showing that if they have help taking the medication, it's much, much more effective. So you can see that here, the monitored versus unmonitored, and the abstinence results in a bunch of trials. You can see that they're really quite different with monitoring. So if you do have a patient who's motivated enough and someone who can monitor the treatment, that's when you might consider disulfiram. Then there are a bunch of non-FDA approved medications. I talked about topiramate. It's active at glutamate receptors and GABA receptors, and I've given some of the dosing. It is really quite effective, but it does have some cognitive impairment associated with it, so it may not be ideal for older adults, but it does have good evidence. Gabapentin, if you're going to use it, you want to get up to 1,800 milligrams per day in divided doses. My experience with this medication is that people with alcohol use disorder like it. It moderates some of the anxiety, helps with some of the sleep disorder that people have, and there's moderate evidence for it, but it is familiar to many physicians. So I would encourage, especially if people have another indication for gabapentin, to consider it. And then baclofen, we thought it was going to work, but then there was a study that really didn't confirm that. It is safe in liver disease, and it may be a dosing issue. They may need to go higher than we usually go. So choosing a medication for alcohol use disorder, naltrexone, again, it can be used in active drinkers, unlike others. And if they have a family history or a lot of craving, those seem to be predictors of response. Acamprosate, definitely safe in liver disease. And if people are on opioids, then that would be another reason to go to acamprosate as the next line treatment. It may have a better response in folks with anxiety or who've had withdrawal in the past, a family history, or late onset drinking, maybe in women. And disulfiram, really, it's going to be restricted to those people who are really motivated and have some supervision around their adherence to the medication. And then choosing medications, I think the future is really about a lot of genetics that's being done around these medications. There's an example here. This is a study of a particular genotype and looking at naltrexone in folks who have one variant or another. You can see on the right with the ASP40 that folks who got naltrexone had a really high percentage of people with good clinical outcomes compared to placebo, whereas if they didn't have that version, they had a different version, it was really no difference. So I think the future is trying to figure out more things like this and how we're going to be able to match medications to people with alcohol use disorder. I'm going to talk a little bit about one of the main studies that's been done with alcohol, looking at medications and psychosocial treatment. It's called the Combine study. And these are some outcomes. This is a large trial, 16 weeks with a large N, looking at medication management and a placebo. So these are people who think they're getting a medicine or might be getting a medicine just with regular follow-up like a primary care might do. And you can see they had a pretty good percentage of people with good clinical outcomes. It was improved when you went medication management, placebo, and added what they call combined behavioral intervention. So more counseling and more cognitive behavioral therapy and motivational interviewing. You can see that it goes up. And medical management and naltrexone had almost the same outcome. So this is where we get the idea that maybe we don't need a large psychosocial intervention. Maybe we're going to get just as much bang for our buck with medication and medication management. This would be something that could be potentially done in primary care. The combined study, this is more data from that. This is drinking outcomes before, so everybody was drinking, and then people went during the trial, much better outcomes, and then a year later, the trial is over, they're right back where they were. And that is consistent with alcohol dependence being a chronic disease, and this is how we're conceptualizing addiction these days. I mean, you can imagine that these same outcomes with insulin or other medications for diabetes. You stop them and they get worse again. So it does require ongoing care, and I think the main point here is that we should be thinking about alcohol use disorder as a chronic disease that we can start to treat better even in primary care settings. So the pharmacotherapy, these results are not mind-boggling. You saw the numbers. It's modest efficacy, but there may be future in individualizing treatment. Naltrexone is really the first line therapy, Acamprosate and disulfiram after that, and maybe some of these other medications if there's good reason for them. Therapy or medical type counseling can be effective, and then there is some data that if you treat anxiety, depression, along with the alcohol, you may reduce consumption as well. So treatment effectiveness, those medication outcomes are not fabulous, but if you look overall for treatment effectiveness in folks with alcohol use disorder, you see that about two-thirds of people who've gone through treatment do have reduction in alcohol consequences and consumption. A third are absent or drinking moderately without consequences. And treatment effectiveness, they've done lots of cost effectiveness trials, and the benefit of alcohol and drug treatment to society really outweighs the cost by 4 to 12-fold, depending on what kind of treatment. So these are treatments that work and really need to be promoted. However, we have a problem with getting them to happen. So this is some commercial pharmacy claims data showing how many people who get naltrexone for alcohol use disorder actually get a full course of 6 months, and it was under 20%. So 14% got 80% of a 6-month course. So we don't do very well delivering the treatment. And then the number of people who have alcohol use disorder who get treatment, it's about 8% of those who have a problem, 92% don't get treatment. And then another study showed that where it was comparing a bunch of conditions about what percentage of recommended care is received by folks with alcohol dependence, and it was the lowest one. Most of the other conditions averaged about 50%, and alcohol use disorder, it was 10%. So we don't do very well with these problems. And then specialty treatment, is that the answer? Well, probably not, especially if you're trying to figure out how to deliver medications. Most programs, more than half, don't even have a physician. Most have part-time physician, and only a few have even one full-time physician. So most of the medications, if they're going to get delivered, are going to be delivered in primary care, even if they're accessing specialty treatment as well. And then there's some emerging models of how to do this, how to deal with alcohol dependence in primary care. The collaborative care models are being experimented with now. These are modeled on delivery of depression and anxiety treatment in primary care, where the primary care doc does the medications, and then there's a some kind of collaborative care nurse or case manager who follows patients along, make sure they're taking the medicine. These have a lot of evidence for anxiety and depression, and are being applied to alcohol. So having a nurse intervention with doing some outreach, and then having that nurse access to some expert advice about medications, and then emphasizing being on the medications and doing the laboratory monitoring. Another model that's emerging is more of a harm reduction model, doing a trial here in Seattle of monthly naltrexone injectors among folks who are really heavy drinkers and recently homeless, and really getting some good results in terms of the outreach and engagement of these patients. It's coupled with more of a harm reduction model, not telling people they have to stop to get treatment, but really trying to use a problem-oriented model and what do they want to do to improve or reduce their risk. So reducing drinking, reducing risk is the main thing in these trials. So this is a summary, and if people have more questions about the pharmacotherapy thing, could start getting those ready. But the summary is you're going to screen for unhealthy use. You can use that single question. If it's positive, you want to assess the severity because you're going to do different things if they don't have a use disorder, if they do. If they don't have a use disorder but have unhealthy alcohol use, you want to do a brief intervention, trying to motivate them and follow up with them. And if they're willing to cut back, make a plan. And if you can recommend groups and counseling, and if they do have a moderate to severe alcohol use disorder, and consider medications as well as coming up with some kind of counseling plan. So I'm going to take a break here and see if there are a few questions, or we could just go on. I don't know if people have questions about the medications or.
I was just curious, in the primary care setting, with these models, what is really the recommended frequency of visits that they should be?
Yeah, so if folks are going to get a medication, for instance, it would be kind of like what you do when you're starting an antidepressant. So you see them maybe once, maybe in a week or two, and maybe every couple weeks, kind of thing, to monitor their drinking, seeing if they're taking the medicine, if they have side effects, and really you could do some brief, motivational interviewing kind of thing that we'll talk about next. But I mean, that would be the ideal, and that's kind of where things are headed. Yeah.
Some of these commercial inpatient programs that you hear on the radio, like Schick Shadle, Pato Day, are those what you would call the specialty treatment programs?
Yes.
And can you give me a hint of what they do? That is it just kind of.
Yeah, so it's a question about the specialty programs, especially the ones that are more inpatient oriented, like if they're there for a month or even beyond that. And really those programs are especially important for folks who really need to get out of where they are. They're in a social situation that is really out of control and they can't get away from people who are drinking or using. So it's kind of getting them out of there so that they can at least start to get a little taste of sobriety. But remember that they have to go back to wherever they're going. So that's the trick. It's like you don't want to put everybody who has a problem into one of these programs because they're just going to come out and be where they were before. So, but your question about what they do, they generally try and do a comprehensive assessment and provide a lot of support in terms of either individual counseling and a lot of group. Most of these programs do a lot of group therapy.
And they use medical intervention too, though?
Many of them don't. There's a lot of them that don't. It's actually unusual to see patients coming out of these programs on a medication. It's one of the gaps in our treatment system, and I think one that people are trying to address, but a lot of it has to come back to the primary care doc.
What is the cost of naltrexone tablets in comparison with others?
The cost of naltrexone tablets, it's quite cheap now. I think it's a generic, so it's not expensive. The intramuscular is the one that is expensive, but it is an administered medicine, so it falls under a different category of insurance because you're doing the injection in the office.
And is it best taken for 6 months for optimal outcomes? Is that what you were saying?
The naltrexone, yeah, I would say at least 6 months. And if people are responding well, there's not really a reason to stop it at 6 months. What you'd want to look for is how are they doing in terms of their functioning and their social situation. Do they have a lot of other support for staying in recovery? And if they don't, I would be favoring continuing the medicine. If they really are more established in a recovery system and get a lot of support, then you can start thinking about tapering the medication off.
So Talkeetna is mentioning a JAMA study by Garbut was using naltrexone 190 milligrams and 380 milligrams, yet 50 milligrams per day is the dose mentioned.
That Garbut slide was for the intramuscular, and that was a dose. Yeah, so they used 2 doses, and that's how they decided that the 380 milligram dose was the right one, because there was a dose response. The oral version is 50 milligrams a day. All right. Well, let's go on. I have one more section. Thanks for your patience. This next section is really about motivational enhancement, and I'm really including this as kind of a encouragement for you to learn some more about motivational interviewing and to start to use more evidence-based style of health behavior change counseling. And applying this to a primary care setting, that's why I call it motivational enhancement. It's not the full motivational interviewing, which is a bigger intervention and one that takes longer, so it doesn't work that well in primary care. But there are elements of it that we can apply. The theory of motivational interviewing or enhancement is that change really has to come from the patient. Your goal is to enhance their motivation and their commitment to change. And for me, it's really practicing these and learning these really increases both the effectiveness of our counseling, and it's a lot more fun if you're going at it rather in a kind of tactical way rather than just telling a patient what to do and leaving it at that. So I'm going to divide this into 2 steps for behavior change counseling. The first is enhancing motivation to change, and here I'm going to talk about self-motivational statements, or what we call change talk, as the main thing you're trying to do. And you're really trying to get the patient to understand why their ambivalence and whether the pros and cons of drinking. And then the second step is really when patients already have some motivation. Doc, I'm ready to quit smoking. It would be, if they come in with that, you're really on step 2, strengthening their commitment. What do you do after there's some motivation in place, kind of closing the deal or making a plan? So in terms of times to practice this, think about these techniques before you give advice about behavior change, whether it's alcohol or other behaviors. You might want to think about trying to get a little bit of motivation going in the patient. If a patient agrees to make a behavior change but doesn't, that's a perfect time to think about these techniques. And when a patient expresses some resistance to behavior change, that's another time, because a lot of times patients come back at you with reasons why they shouldn't change and you don't know quite what to do. These are some techniques that can help. I find that this happens a lot in primary care, not just related to substance use, but a lot of other behaviors as well. So eliciting change talk, this is a self-motivational statements. And the theory is that as I hear myself talk, I learn what I believe. So your goal is to get the patient to talk about behavior change in a positive way. And that might be that they're acknowledging that there's a problem, that they have some concerns with what's going on now, that they want to change or they need to change, or they might even just be willing to change. Any of those kind of talk, that's called change talk. And it's the opposite of arguing. It's the opposite of resistance. Resistance are really statements that oppose behavior change. And in the motivational interviewing world, they've really got this, and even in primary medical care, they've documented that patients who express more resistance are less likely to change, and that makes sense. But they've also demonstrated that the clinician style of counseling is associated with resistance talk. So a more confrontational style is associated with more resistance. And motivational techniques really tend to minimize the resistance talk. That's what your goal is. Get change talk, minimize resistance talk. How do you do that? So asking for change talk, the easiest way to do this is tell me what concerns you about your drinking or whatever behavior you're talking about. Or tell me why you think you might need to make a change in this behavior. And really there's nothing that they can say that wouldn't be change talk. Whatever they might say, I don't have any concerns, and then you're on to something else. But most people will have something that they might be concerned about, even if they're not ready to make a change. And then if they do come up with something, then you just want to get them to talk more. And how do you do that? Well, tell me more about that. You're open. My favorite question in medicine, tell me more about that. And get them to talk more. Or you can reflect, so you're worried about your health with this problem, or your marriage with this problem. And then what else? So you're getting them to talk. This is the intervention. This is how to get people talking to themselves positively about change. The importance scale is a motivational interviewing technique that gets at the same thing. On a scale of 0 to 10, how important do you think it is for you to change your behavior? And then whatever they say it's a 2. It's not all that important. Why isn't it a 0? Why isn't it less important? And really all they have to say is what they might be concerned about. Maybe it was somebody else who talked to them or whatever. But whatever they say, that's change talk. So you, again, want to get them to say more about it, and trying to understand and get them to talk more about what it is that they're concerned about. Any other concerns? So open-ended questions and reflection are really aimed at getting to do more change talk. Reflection is a key idea in motivational interviewing, and I would say in medical interviewing. It's really an important technique. It's not just repeating what people say, but using those statements to clarify the patient's concerns and to get more information to guide the interview. It isn't about arguing with them or correcting them or even teaching them about what they need to know. You're trying to get an understanding of what's important to the patient. And doing this is important before you make a plan. So before you decide, is there something you want to do about this, do some of this change talk and reflection. Meeting resistance in motivational interviewing, we're all going to meet that, and you never want to meet it head on. You can say, you can assess the pros and cons of drinking. So it sounds like you're really attached to your drinking. Tell me why. What's the good things about it? And then follow that with what are the not so good things. So you're at least getting some back and forth in the patient's mind about what's going on with their drinking. You can even do some reflection to do this. So you don't see any problems, or you can't imagine life without alcohol. I mean, you can actually amplify what they're saying and they may come back with, no, that's not exactly what I meant, and clarify and get onto something that's more about change. If you have done some pros and cons of drinking, you can meet resistance by contrasting. So you're worried a little bit about your liver and your liver tests being high, but on the other hand, it's really hard because all your friends drink and that's your main social outlet. So just trying to get them to see the contradiction, the ambivalence that they have. If you do get a lot of resistance in primary care, I think it's a great setting. Just go on to the hypertension for a little while and then come back around, because hypertension might be a great one. You're taking your medicines, your blood pressure is still up. Oh, by the way, alcohol makes it really hard to control your blood pressure. That may be another reason to get to think about change. And then for motivational interviewing, kind of the last straw, if you're getting a lot of resistance, and the main attitude there is, that it's up to them to change. So you may decide not to change at all. It might be too hard for you to change. That's up to you. So that's the dealing with resistance in motivational interviewing or enhancement. So we've gone over this first step, enhancing motivation to change, and then what do you do when people have some motivation and are thinking about change? How do you deal with that? So behavior change is really hard. I don't know if you've ever tried, but it's difficult to change your own behavior. And older adults, they may have a lot of chronic conditions. They may have a lot of behaviors that would be worth changing. and they may not understand, they may have lack confidence or knowledge or skills. And really, your goal with this first part of the conversation, you're sort of summarizing what's good about the current situation, what's good about change, and then you want to summarize that. So where do we go from here? That's kind of the key question in motivational enhancement, is making that switch. Now we're going to talk about what the plan is. And really the timing of this is important. So moving from this change talk to commitment to action is key. If you try and get this to happen too soon, the patient might not be ready. If you kind of beat a dead horse, you kind of lose determination. So trying to figure out, spending some time enhancing motivation with the change talk is a good idea. And realize that patients may go back and forth in this from considering change to being more motivated to change. If signs that folks are ready to change, they stop doing the resistance talk, they ask fewer questions, they kind of feel a little bit more settled or resolved or peaceful, they start making more of these self-motivational statements, and they start to talk like they're imagining what it might be like if they did make a change. And that's when you're ready to go. If patients are not ready and you've gone through some of this, and you'll recognize resistance talk by the patient, they miss their appointments, and that might be a reason why they miss appointments. They're just not ready to engage in this anymore. They may, if they're coerced by the circumstances, they dealt with that. They may be indecisive or guarded or resistant. And really, it's probably better to explore their ambivalence rather than kind of pushing through to, okay, are you ready to quit, kind of thing. So if you are moving in towards strengthening their commitment, towards making a plan, you want to get it from the patient. Would you consider making a change? What are you thinking? So getting it from the patient first, elicit their ideas. How are you going to do that? And then you can reflect those and summarize those. And then if you're going to if you want to give some input, the key thing would be just asking whether you can offer other kinds of options. And doing that before you step in with your plan is a good idea. So you're always communicating that it's up to them about what to do. You can continue as you are or make a change. You're going to review those consequences of action and inaction. And you really want to balance this advice giving versus or information giving with emphasis on their choice. The confidence scale is another motivational interviewing technique that you can use on a scale of 0 to 10. How confident are you that you could make a change? And if they say 5, you could say, are you not less confident? And that kind of encourages them to talk about kind of the strengths they bring. Maybe it's other people who might help them. And then you could also use that question and say, why are you not more confident? And that may bring up barriers to change that you need to address and deal with and make a plan about. So that's how you would use the confidence scale to talk about both sides of that equation. And then elements of a change plan, what's the change going to be? Why am I going to make it? How am I going to do it? And who's going to help me? And how will I know if it's working? And what are some of the barriers? So these are things that we're pretty familiar with, I think, when we talk maybe about smoking cessation, and it can apply to any kind of behavior change. So asking folks for a commitment, are you ready to make this commitment? And if they're not, they're really hesitant, it's probably better to defer a decision and just say, we're going to talk about that later. And for me, a lot of that is just figuring out about the follow-up. It's like, and for me, I try and put in my notes where we got to in these kind of conversations. Did we make a plan that they were going to try and cut down, or did we not get there? Something in your notes so you don't have to start the conversation from scratch, but can kind of review where they are at on the next visit. How did it go? And then, if depending on what happens, you may want to do some more change talk, renewing their motivations. What do you remember is the most important reason to change? And then redoing more about commitment, reinforcing that it's up to them and that they have strengths that can help them change. So behavior change counseling, I just encourage you to try it a few times. See if you can elicit some change talk as the first thing you're going to try, and then enhancing motivation to change through these self-motivational statements. What are your concerns about your drinking? And then try out the importance scale, see how it goes. And then strengthening a commitment to change when you're trying to make a plan with a patient, trying to use the confidence scale, try and figure out what elements of a plan you can come up with, and then document that and follow up with the patient. A couple of resources for you, especially the top one, Motivational Interviewing in Healthcare, is a great book if you're interested in this. It's got lots of examples and techniques, and it was very helpful for me in learning some of these techniques. And then, so this is just a summary slide for the whole talk. Alcohol problems do present differently in older adults. Screening, assessment, and diagnosis determines which treatment you're going to do. If you get folks who have unhealthy alcohol use but not an alcohol use disorder, you want to think about doing brief interventions and using some of these motivational techniques to improve that. And then for folks who do have alcohol use disorder, consider the pharmacotherapy, consider how you're going to deliver it and how you're going to follow up with patients. And then practice these motivational techniques. I think they really improve your interactions with patients. They build the rapport. And for me, it really improves satisfaction in my own care. And so I really encourage you to work on those. And I think that's all I've got for the talk. Yeah. So thank you, and I'm happy to do some more questions if people have them.
So, oh, go ahead.
So it's great to see you adding the change counseling along with the pharmacotherapy. And I can only imagine that doing both together is the best outcome. Any studies as far as showing that, doing just pharmacotherapy or the combo or just?
Yeah, so the question's about the combination of pharmacotherapy and this motivational enhancement. And really, the spirit of the motivational enhancement can be put into just medication management. You're just talking to the patient. Are you taking your medicine? Why are you taking your medicine? Why, trying to encourage folks to talk about the reasons for wanting to be on the medication and any barriers that they've had to that, side effects or other kinds of barriers to changing their behavior. So it can really be integrated right together with the pharmacotherapy. In terms of data supporting these and trials that have done that combined study that I showed, where the brief medication management plus the medication seem to work as well as the medical management and a lot more treatment. So you kind of want to take it step at a time, give the motivational enhancement, the pharmacotherapy, and see how people respond. If they respond well, great, keep that going. If people continue to have trouble, you may have to change medicines or change the dose, or you may need to get more psychosocial support, more intervention going. But you can really do a lot of the care at those first levels.
So in terms of motivational techniques, one of the questions is, would you consider alcoholism the same as trying to lose weight or stop drinking coffee? Maybe how you would use those techniques differently in alcoholism versus the other?
So alcohol versus overweight versus
stop drinking coffee.
I
think they use them in
so I think
smoking cessation.
Yeah, motivational interviewing has been applied to all those for sure. And there is evidence in support of that counseling style. I think for each of them has their own consequences in the person's life and interactions with their medical problems. But they're really all, I'm not sure about the drinking coffee one. I think there's not that much evidence that matters. But in terms of obesity, alcohol, they're both chronic illnesses. They both have a large behavioral component, and they both can respond to medical interventions of different kinds. And motivational interviewing can be a part of the delivery of those interventions.
And I think you've talked a little bit about this, but do you have anything more to add about the costs of naltrexone tablets and insurance coverage issues?
There have been some, in the past, there have been some issues in the Medicaid program in Washington State around coverage for any of the medications for addiction, really. And there still are barriers in terms of dealing with opioid addiction. But my experience now is that there are many fewer barriers to naltrexone, especially the oral formulation for even Medicaid patients. Most insurance does seem to cover that. So I don't think, and it is a lot cheaper than the injectable. Most insurance companies will require a trial of the oral before approving the injectable. But we haven't had a lot of problems with that, and especially since it's this administered in the clinic version, it seems to be doable for the most
And
part.
the Medicare Part D, do you know anything?
I would say the same for that. Those programs actually tend to cover most of the medications pretty well.
Okay, and then Cheyenne is wondering which treatment strategy is most effective for minorities?
For minorities. If we're talking about alcohol use disorders, I don't think that there's a lot of information to say that there are disparities in many kinds of treatment for people of color, and I assume, although I don't know the literature, that would apply to treatment of addiction. But I don't know that there's data supporting any particular approach to treating these problems in people of color or particular subpopulations. I think always due to stigma, stigma is a problem in addiction, and it also overlaps a lot of other problems in medical care. And so being upfront about that and presenting that as a possible reason why people might have trouble accessing treatment, that can be helpful in breaking the ice and talking about some of these issues more openly. But I don't know of data supporting one intervention or another.
Other questions, folks? I don't see. Okay, I guess that's it.
All right, well, I
Thanks
appreciate
so
your
much.
attention. Thank you.